for the Monday town hall session begins right here at the Kenyatta International Convention Center, the absolutely stunning convention center here. And this is where we're talking about the larger cancer burden, this happening on the Breast Cancer Awareness Month. But we're speaking about the larger cancer burden because there are some troubling statistics from way back in 2020. 47,000 cases annually, 32,000 deaths annually. That is 80 deaths per day. Are we getting better or worse? This is the conversation I'm having with the experts here, plus some cancer warriors as well in the audience who will tell us their story and what the gaps they see. Let me introduce my guest, starting from my immediate left, Dr. Elias Meli, CEO, National Cancer Institute of Kenya. Thank you so much for making time. Dr. Gordon Okomo is here. He's the County Director of Health, HomaBay, and also the Chairman, County Directors of Health Forum. Thank you so much for making time. And Dr. Omar Abdi Hamid is a clinical oncologist at the Garissa Regional Cancer Center. Thank you very much for making time. Dr. Meli, before we get into the conversation with the cancer warriors, what really is the mandate of the National Cancer Institute of Kenya?
Well, thank you, Trevor, for inviting us this evening to speak to Kenyans and to speak to the world about the burden of cancer in Kenya. It is really a concern to our country, and not only our country, regionally and globally, that the burden of cancer is higher than ever before. And in recognition of this burden, our country has made a very deliberate effort to make sure that we handle this in a very coordinated manner. And in 2012, our National Assembly managed to establish the National Cancer Institute of Kenya. This is a saga under Ministry of Health. It is a semi-autonomous government agency, and it was in the interest of making sure that there is a more coordinated response to cancer in this country. And there is a more coordinated response using a multisectoral approach and also intersectoral approach. It is because people were dying. And Trevor, to be very honest, every village has someone who is diagnosed with cancer. And every village has lost a Kenyan, a loved one. Every family has been affected. And therefore, it is not business as usual. We must have a very coordinated way of addressing. This is one disease that, unfortunately, causes a lot of socioeconomic challenges. It affects us physically, it affects us economically, psychologically, socially, and even spiritually. Sometimes we wonder, why do even God exist? Why is this disease that terrorizes our body? You know, we have many survivors who are here, and we have, unfortunately, those who we have lost to cancer. And I always, every other time when I speak about cancer, I become emotional, and I would always want to observe 15 seconds of silence for those who, unfortunately, we've lost to cancer. And if we can do that, I think I would really appreciate before I add my voice to that.
Okay. We can hold a moment of silence.
Thank you very much. So our leadership currently, and even the leadership that have existed since National Cancer Institute of Kenya, saw a reason through Ministry of Health to establish this institute, which its mandate is cancer prevention and control. That is one statement, but it means so much. It means we want to address the issues of cancer through the entire continuum of care. And we are looking at interventions on how to address this cancer menace from prevention. And the mood of this current leadership under our able President, Dr. William Ruto, is prevention. It's primary health care. You know, and we are also looking at early detection. We are looking at screening for early diagnosis. We are looking at proper quality diagnosis. We are also looking at treatment, and treatment which is quality, either with palliative intention or curative intention, depending on the disease. There are those who, fortunately, they survive, and we would like them to have quality life. And to address this, the National Cancer Institute of Kenya was established and has several functions. I'll just summarize a few because I know we don't have much time. Yeah. Number one, it is this institution that provides advice to Ministry of Health to our cabinet secretary on priority intervention in cancer prevention and control. And it's good for the public to know that government has established institutions so that they can know who to ask for what assistance they would get from who. And beyond that, as it advises the Ministry of Health, because we are semi-autonomous government agency, just like KEMSA is, just like NHIF is, just like KMTC, and many other sagas who are under the Ministry of Health, under currently our able leadership of our CS, Madam Susan Akumicha, and our PS Medical Services, Mr. Hari Kimtai. And in addition, as we advise, we coordinate. Because in this country, there are so many people who are doing a lot of activities, interventions to address this cancer issue. But we are now coming in to coordinate everybody, whether you are a healthcare worker, all the stakeholders, whether you are a healthcare worker, whether you are in civil society, whether you are in training institutions, whether you are conducting research, whether you are conducting screening, we want to give a joint report to the country in a very organized manner. We also participate in making sure we have solid, candid prevention programs by creating awareness. We are doing cancer mainstreaming across the country to our ministries, departments, and agencies, and also to the public, so that they can know what risk factors are there. Because it's really expensive to address cancer once it's been diagnosed. And we can intervene with prevention. This is one of the functions of the National Cancer Institute. We are here to encourage, prevention through, I can mention one intervention which is working. Nobody should die of cervical cancer. It is sad that unfortunately we still have cervical cancer being #1 killer in our country. And we need to continue educating our people. HPV vaccination is available for our girls before 15 years. And we've been called to eliminate cervical cancer by 2030 by WHO. I do believe that it's possible for us to do this. Just a vaccine is enough to boost the immunity of our girls before they engage in sex in future, before they interact with HPV virus. And this is enough to kill HPV virus that causes 99.7% of cervical cancers. That is one intervention, very simple. And NCI is going to work with all the stakeholders, both at the national government and county governments, both state and non-state actors, to make sure that we are going to eliminate cervical cancer. There are many other interventions. There is screening. And we are looking at all that. The other very important role that NCI plays is to make sure there is quality care. We are regulating cancer space. Many people have complained about poor quality care. They've been misdiagnosed, they've been overtreated, undertreated. We are coming in to give you confidence that we have developed guidelines that are now able to ensure when you walk into a facility for diagnosis or for treatment, we are inspecting, we are accrediting, and we are designating cancer diagnostic and treatment center for quality, because that is quite important. There are people who've traveled abroad and they would be like, oh, I've been told I'm suffering from, a chest infection, and unfortunately it became lung cancer. So we are here to make sure that within the country, with the investment that this Ministry of Health has put in cancer and the national government in general, really assures you quality as a Kenyan. And we also, to make sure you get that quality treatment, we are involved in capacity building, both formal and informal, structured and non-structured, curriculum-based and non-curriculum-based, to make sure that even the community health promoters that were launched by the president the other day have a cancer message. What are they discussing about prevention? What train are they having relevant message that is not going to mislead, so that we make sure people are able to be referred, people are able to be guided. That is how we will win prevention in the community. And let me add my voice to the fact that we have healthcare workers that must get quality training. We've had training abroad. The nurses, the laboratory technicians, the doctors, pathologists, radiologists, the oncologists who are the cornerstone of running, cancer care in an institution. But now we have more. And cancer research is one of our pillars. In this country, we've had very limited little cancer research. And right now, Last week, we launched our cancer research agenda in Mombasa, and NCI is going to lead in all cancer research. We are going to conduct cancer research within, and we will coordinate and collaborate with all other institutions, individuals that are conducting research, because we have to answer our questions. Yeah. We've been treating our patients using foreign data for a long time. And sometimes using foreign data, participants in this research are people who unfortunately are not of our descent. Genetically, we are different. And sometimes we may be using their protocols. Unfortunately, our genetic makeup would probably, when we metabolize, when we break down these drugs, when we use these interventions, it may underdiagnose, it may overdiagnose, it may undertreat or overtreat. So we want to conduct our local data. And finally, we are playing an advocacy role to make sure that you who have been diagnosed with cancer, to make sure you who has not been diagnosed with cancer, we make sure that we prevent or you access. There should be equity. There should be diversity, and there should be inclusivity of everyone in this journey. And together, we will win this battle.
That's an interesting approach, and I'm sure there are many questions that will come regarding your mandate there. But Dr. Okomo, let me bring you in on this. What is the current state of cancer in the counties? Because Dr. Meli has mentioned that the situation is higher than ever before.
Yeah, thank you very much, Trevor Mbija, for letting us come and talk to wananchi. And I must say that health is a right, and everyone has the right to get the highest quality healthcare in this country. What Dr. Meli has said is real. Cancer is real, and we're seeing these numbers grow up in the counties, in every county, though with the different geographical disparities and even types. The type of cancer that we get in Garissa might be different from what we get in HomaBay and other parts of this country. But also, again, we realize that we only have, I think, 8 regional cancer centers in this country. So many pockets of counties, many counties still cannot access the high-quality services that Professor Meli has just talked about. People still take long queues. People still go far away from their counties to go and seek those high-level interventional services. And you look at this, cancer treatment has a lot of protracted hospital stays. People leave from the villages to the cities. They stay there longer. They leave alone all the activities that they're doing, the economic activities they've been doing in their communities. People pay for their rents, for their stays. And if you look at that economically, it hits at that poor person. Then again, in the counties, you realize that in as much as we are pushing for screening at the earliest time possible, using our community health promoters, using all our facilities as screening points, we still have that challenge. Even those who have NHIF, the social insurance for this country, that package is not there. So we'll urge, through National Cancer Institute and our colleagues, can we see into it, can we have a candid talk, a conversation that can make even our NHIF have a package of screening? This one will motivate many people to come for screening, to go for screening. Because nowadays, anyone who comes asks, do you have NHIF? Are you offering NHIF? Or are you offering this different type of insurance services? So I think there are disparities in the counties, but the reality is
there's a rise.
There's a rise.
Okay.
I think this also because of maybe we've brought screening services closer to people. Yeah, there could be that detection epidemiological approach. And I think we need to be candid in this country. Let's sit down and having a candid talk. Just the way, I think cancer is more serious than HIV. When HIV struck, people came together and it was an emergency. I think that's where we should be talking. Okay. Yes.
Dr. Omar, what is the situation in Garissa specifically?
Yeah, so I think, thank you for having me, Trevor. It's a pleasure, and it's a great honor to share a platform with colleagues. I think people are wondering, Garissa, for the first time, people talking about cancer services. If you didn't know, now you know. There is a high-level comprehensive cancer care center in Garissa. It's called Garissa Regional Cancer Center, courtesy of the Ministry of Health, which we're very grateful for. It's a huge, a huge milestone in the cancer care landscape, especially in northern Kenya. I will not sugarcoat it. That region has been marginalized for a longer time. It's been playing catch-up in many facets of this country's development. And we're really grateful to the government of Kenya and under the Ministry of Health to have taken that really bold step in decentralizing cancer services. And even more so in a concept that I'm very, very proud of, I'm passionate about, called cancer care equity. So coming back to the state of cancer care in Garissa County as a general, I'll talk about the success story. It's not good to always talk about the negatives. The success story is that we have a center that offers chemotherapy, radiotherapy. We have 2 specialists who are consultant oncologists. We have myriads of healthcare team, nurses who are trained in oncology, clinical officers who are trained in oncology, medical officers. We have a whole team that really comprises of the able team to take care of these patients. The state of cancer in Garissa is something different. And I was talking about the patterns of cancer epidemiology, which means disease of different people and different areas, is that the Garissa Cancer Center cancers are quite different from the other parts of the counties. Yeah. As Dr. Gordon was saying, not all patients, not all cancers are the same. Cancer itself is not a single disease, let alone the people it affects. So it cuts across different demographics, different race, different socioeconomic status, different immunity level, different heritage and genetic susceptibility, all the different lifestyle, all these factors really feed into what type of cancer you have, and even though that should not define what care you get. Yeah. Okay? So I think in a nutshell, Garissa, the state of cancer care is the services are there. Since last year, June, the health CS Nahumisha and Madam Nahumisha had launched officially this year, February, but it was actually working from last year and April, yeah, all along. Okay. Maybe if you're asking about the type of cancer that is more common in the northern part of Kenya, is more of head and neck region. Yeah. We tend to see a lot of cervical cancer and breast cancer in other parts of the counties in Kenya. But those are relatively low, especially the cervical cancer. Yeah. Is quite low in northern Kenya. But what is disproportionately very high, that requires even a tailored approach in terms of the support we get from Ministry of Health, is the huge upsurge of head and neck, the tongue tumor, anything inside, the voice box tumor. We're doing research. Yeah. We have started the first batch of our research work, which I'm proud to be leading, is that we wanted to get first a snapshot of what type of cancers we have. Now we know through our daily Monday clinics and Tuesdays and even the research we're putting out, yeah, that we know we're affected highly head and neck tumors. Next, we are collaborating with the Ministry of Health and even partners from international collaborative research to find out literally what is going on. Is it genetic? Is it the environment? Is it the being even in that region? Yeah. So we're really into finding the nitty-gritty of what is happening.
Okay. And this is where I want to bring in the cancer warriors who are here. But Dr. Meli, you had mentioned that your role of NIC is to advise Ministry of Health on the priority intervention areas. What are the gaps that you're seeing when it comes to dealing with the cancer in the country today? What are you telling them are the priority intervention areas?
Well, thank you, Trevor. Remember, Ministry of Health is the overarching sector that is mandated to make sure Kenyans are healthy. And specifically, as they address many health-related issues, we are championing on cancer issues specifically. Mm-hmm. And we are a custodian of all cancer data in the country. And using this data, we are advising Ministry of Health that, look, a lot of our patients at this point are presenting at advanced stage. In fact, 60 to 70% of our patients presenting to the hospitals are advanced disease, stage 3, stage 4, which unfortunately may not be curable. And we are advising our ministry that as we invest resources, can we then invest on how we can reduce these advanced diseases to match, earlier diagnosed diseases, stage 1, stage 2. You remember the MES program in 2013 that enabled every country to, this is Breast Cancer Awareness Month. As much as we want to bring awareness for all cancers, but in 2013, there was a very deliberate effort to increase early diagnosis for breast cancer, and the government invested mammograms 2 per county, so that as we educate Kenyans, we also attach them to equipment that is available in hospitals for early diagnosis. That is the only way as a country we can get survivors. If we are able to diagnose stage 1, stage 2, we are likely to treat them with curative intention using whichever modality. And government had us. However, we did not utilize these mammograms to the maximum. And we are now, again, round 2, trying to sensitize people, why it is very important for you to do screening, for early diagnosis or prevent. Dr. Hamid Omar mentioned about head and neck. We know there are many, many risk factors. There are chemicals, there is pollution everywhere. We need to narrow down and figure out which one could actually be the risk factors we prevent. But we know for breast cancer specifically, because there is a big role that estrogen plays in diagnosis of breast cancer. So then we may not reduce over estrogen, but then we may want to advise more on, self-breast examination, clinical breast examination, use mammography for early diagnosis, and we are asking our ladies and also men, present yourself for screening. This is the only way we can save your lives. Remember, every woman in life, 1 in 8 women is likely to be diagnosed with breast cancer. And these women are in our country. These women are in this world. And we don't know whether it will be you.
So how frequent should these screenings be?
Now, we are asking, because screening, it depends on the density of your breasts. For the younger ladies or for the dense breast, we are asking you to have, a clinical breast examination by a healthcare worker. It is more reliable. You are likely to pick lumps. You are likely to pick masses. We are asking those who have low-density breast cancer, and more often these are the elderly women, 50 years and above, who their estrogen levels have gone down. We are asking them, go for mammography. It's a very simple test. It will pick some, for radiologists who report, they will see some tiny light things called calcification, and this, can be an indication that you are likely to be having cancer, and we will go ahead to, and we can, every 3 years, is adequate. In fact, I am happy that our country now is going the digital way. We will be having data for everybody through, the community health promoters, for everyone who has been screened. And we will be reminding you that you are due for your breast cancer screen. That's what's happening in the West. So if we do that, this is one intervention that National Cancer Institute of Kenya is advising. It's an example, as you ask, on how we can advise the ministry to intervene. The other one is establishment of regional cancer centers. It is quite costly, it needs resources. We know, even as we try to prevent, there are cancers that we still need to actively treat. And we still need to treat them. It is different from malaria. We need to invest in treatment as we increase on prevention and screening interventions. We still have to treat with quality, interventions, those who are diagnosed with cancer. And we are now taking the approach of regional cancer centers. We have 3 regional cancer centers. It's an advisory from National Cancer Institute to the ministry. From our data, there is high density of cancer cases in this region. Please, let's have a center. If it is Kisii, right now we are looking at Kisii, we are looking at Kakamega, we are looking at Meru, we are looking at Nyeri. And we have also the support from the national referral hospitals, KUTTRH, KNH, and Moi Teaching and Referral Hospital carries the bulk of cancer care at this point. We want to debulk, decentralize further, so that people can access care close home.
Dr. Okomo, in HomaBay, for example, I know Dr. Omar mentioned that theirs is head and neck and head cancer. What kind of cancers are we seeing in HomaBay?
Yeah, thank you, Trevor. Dr. Omar said that they experience head and neck. In HomaBay, the story is different. If I could mention the top 5, number 1 is the CA cervix, that is the cancer of the cervix.
Yeah.
Number 2 is breast cancer. And number 3 is esophageal cancer. Then, of course, we have the cancer of the prostate. And then there's another cancer called Kaposi's sarcoma, which is as a result of advanced HIV disease or immunocompromised patient. And when we're in such a situation, you realize that you have a complex number of different cancers. But again, in HomaBay County, under the leadership of Her Excellency Gladys Wanga, we've come up with a robust oncology team, where we have an oncologist, I think was one of Dr. Abdi's colleague, and we've tried to set up a team so that at least we see as many cases as possible, from screening, consultations, surgical, and of course even the mammogram that Daktari has talked about. We appreciate the MES scheme. Has really helped many people who could have walked or could have moved to other counties to seek treatment. But beside that, we're also coming up with a comprehensive cancer center, where we'll have even radiology, radiation therapy, immunotherapy, and of course targeted therapy. So that at least in that region of South Nyanza, we don't let anybody go far. You've seen people talk here that it's expensive to travel, it's expensive to get this treatment, but at the end of the day, we want everyone to get the services next to them. That's what UHC is all about.
Okay, let me hear from the cancer warriors who are here. I think you have the microphone. Just start with your name and state what your main concern is when it comes to dealing with cancer in this country.
Okay, my name is Lucy Kariuki, and I'm a breast cancer champion. My main concern is financing. During my time, NHIF paid for me, and there was no top-up. But as per now, you have to top up or pay upfront a year or 2 years. You're talking of somebody who is already traumatized because of the disease, and they don't have the money. Nobody has money under the bed that you're just going to pick the money and go and pay. Then there's lack of counseling. You're just told you have cancer. What do you do with that, or what is expected of you? And something else that has been missing is inclusivity. We have survivors. In the data, they said that the cases that were diagnosed is 47, and the mortality, you said, is 32. Why is the rest? We are demanding our share for survivorship, because I think the game changer this time around is using of survivors, use their lived experience, their stories, and I think, as you said, that they used in HIV, they used those people. We are very instrumental with this because we have the lived experience. So I can relate what it is for the hair to fall, for a person to move without a breast, as opposed to of a doctor saying that your hair is going to fall. So you'll find that every time I talk to this patient, we have something in common. And for us, we always tell them that the journey is very difficult. For us, it's the lived experience. It's not easy. But we have to come up and try and encourage ourselves, and even engage the stakeholders, the policy makers. They're making policies for who? Do they call us on the table and ask us, what do we need? Never there. At least somebody has to call us on the table and tell us, this is what we are doing for you people. Is this what you need? How do you feel about this? So inclusivity, there's a very big gap. NHIF, paying upfront a year or 2 years, and counseling services from my end.
If you don't mind me asking, at what stage were you diagnosed?
I was in stage 2B.
Stage 2?
Yes.
Okay, so was it, what happened? Was it just routine checkups, then you found out, or what happened?
No, it was not the routine checkup. I had stopped nursing my 1.5-year-old son, and usually women we develop lymph nodes under our armpits. So this one lymph node refused to go even after 3 months, and I developed another mass on top on the other breast. So when I went to the hospital, they said this could be mastitis because we just stopped nursing the small boy. So I went to seek a second opinion to another hospital, and they said that there was some fat residues and something not to worry about, so they could do it locally. So when they went inside the breast, of course it was done locally, so I could hear them talking. They said that it is a tumor. So I was given my biopsy to take to a pathologist, And when I took it there, it turned out to be breast cancer. They said it is grade 1 carcinoma. But then when I went to seek treatment at KNH, when my breast was removed, when they had the big mass, it turned out to be stage 2.
Okay.
Yes.
All
and
right.
The normal routine, I did my chemo there, the 6 chemos, and I did my radiotherapy there. The only top-up that I did by that time was 2,000.
Okay.
Yeah.
All right. Thank you so much for sharing. I think you're very brave to share that story with us. We're taking a quick break here on Monday Report Town. We're going to come back and still hear more stories from the cancer warriors here in the audience, and then we'll find out from the policymakers and how they think those gaps can be dealt with. All right. Keep your views coming also at Trevor Mbidi at Citizen TV Kenya. Use the hashtag Monday Report. See you in just a bit.